So I'll talk to you about how we incorporated navigation in our practice. And I think it's been really fascinating, and Ilya alluded to it. We start as a resident, we started using navigation for brain surgery. And I always, for me, it was no brainer to then translate that into spine surgery, but it took really a good 10 years struggling in the OR with every case with the ISOC at the time, where I had to do the spins pretty much myself because the X-ray tech didn't really know how to do it, and it took 10 years to really get it to the point where it was really efficient. And then now with the new technology, it's really totally streamlined, and we expanded it to the point where we, as I mentioned, we totally eliminated now fluoroscopy except for lateral surgery. I don't know if you watch YouTube or TED Talks. There's a guy, Simon Sinek, and he talks about the success or failure of companies, institutions. And he says that the mistake that we make, we talk about what we do and how we do it, but we don't really talk about why we do it. And he says that the reason why a company like Apple is very successful and other companies is they really address the why. And I think in spinal surgery, it shouldn't really be much different. And so why do we navigate? And I think the key aspect is really we want to be safe. It's, at the end of the day, it's all about safety for our patients, safety for the staff, safety for us ourselves. And I think navigation has a lot of advantages in that regard. I think data show now that it's efficient. I think in the old days, you could make an argument that, it takes time and so forth, but now that the workflow has been worked out, and I think if you use it correctly, if your team is used to using navigation, it can be extremely efficient and can make you more efficient as a surgeon. And then it enables complex and minimally invasive procedures for many different reasons. And then more and more patients are really picking up on that. And if I call it GPS. If I explain to a patient in the office, we're going to use GPS to put in the screws and the instrumentation, patients understand that, and they will naturally gravitate towards preferring that versus doing things freehand. One of the key papers, and there are a lot of papers about this, but this is a paper that we published a few years ago, was that navigation really decreases the perforations rate of the misplacement rate of screws. Now, let's talk about navigation. And there's a lot of confusion when we talk about navigation. It's a complicated technological phenomenon, right? You've got imaging technology on the one side, and that's intraoperative and preoperative imaging. And that's really then a preoperative CT scan or intraoperative 2D or 3D imaging. On the other side, there's navigation technology. That's 2D navigation software, 3D navigation software, robotic, and now we have augmented reality and virtual reality. So there are really two different types of technologies that come together, and we as surgeons, we kind of have to fuse it together. We have to combine it, and it gets fairly complicated. And I think we should, and that's why I think a study group would be really good to really clarify the landscape for surgeons, for industry, because we use different terms for different things, and I think that makes it unnecessarily complicated. In my opinion, there's no difference between robotic surgery and regular navigation. It's exactly the same thing. It's just how you use it. And it's only going to get more complicated now with augmented reality, virtual reality. I think we really kind of have to clarify the landscape in order to really make sense of it and really define its limitations and its value. So, what I want to convince you of is that navigation at the end of the day increases implant accuracy, which is a good thing. It facilitates MIS and complex surgery. It eliminates wrong level surgery. I think as surgeons, we haven't done really good enough job of really pointing that out. A wrong level surgery in North America is a huge deal. Hospitals pay lawsuits, and we could really we could leverage that and to clarify that navigation eliminates wrong level surgery, and therefore, just for that reason alone, is incredibly beneficial and helpful. In our practice here at Cornell, we pretty much eliminated fluoroscopy for most cases, and now we start using augmented reality, and I'll show you a few cases, which I think is really exciting. And obviously, we'll see many more cases over the course of this meeting. Now, we use an intraoperative CT scanner now that is integrated with navigation, which facilitates the workflow. You can scan if you want. You can scan the whole spine. The image quality is essentially like a diagnostic CT scan. And once we started using that, the step from using navigation just for putting in the pedicle screws to using navigation for everything was very, very straightforward. So now We started using navigation for everything. We got a scan, we plan the skin incision, so you can plan the skin incision in a perfect trajectory for your pedicle screws. We use it for screw placement, and then we use it for placement of the tubular retractor for the decompression, for the cage placement. This is an example of a TLIF case. And then finally, when you get your CT check at the end, of course, we call that total navigation. I'm obsessed with accuracy of navigation. So people joke I should have invested in this 3M company that makes those surgical tapes. I really tape down the patient a lot, but it increases accuracy. Even if you have a patient who's fairly obese, you want to make sure all the soft tissue doesn't move, and that really helps you then with accuracy. There's a big problem with, as Robert mentioned, the spine and lateral surgery kind of bending. We don't have a good solution for that, but for some of the posterior cases, by taping the patient, you can eliminate some of this. We use iliac crest 2-pin fixation for the most part, and you can navigate very safely up to L1, maybe T12. And so we use navigation. We get a spin. We plan the skin incision in the perfect trajectory for the pedicle screw. We make those skin incisions, and we use the single tip or the single stage pedicle screws. There are a number of different companies now who have those available. They have a little K-wire that's integrated that penetrates the cortex, and the screw tip is very aggressive, and it's a single stage, so you don't need any tapping or awling. You just basically put in the screw, and we just submitted a paper comparing this to more conventional screw placement in terms of timing and workflow, and we saw that this overall works really well. And as Juan, I think he mentioned, a pedicle screw takes 1.5 minutes. If you average it out, it's about 2 to 2.5 minutes in our experience, which is much faster than the 5 or 6 minutes for conventional navigated pedicle screws, where you use K-wires and tap and all, and use 10 different instruments that you have to navigate. With this instrument, you navigate one instrument, and you put in the screw. Once we have the pedicle screw in there, we navigate the decompression. We navigate placement of the tubular retractor. We can identify the disc. Patients who have very collapsed disc space, the navigation can help you get into the disc space safely. And then we place the tubular retractor. We do the facetectomy, and the navigation can help you with that as well. We finally place the cage, and so forth. And then we do the over-the-top decompression. If the patient needs the over-the-top decompression, you can navigate that as well. It can show you whether you have successfully decompressed the lateral recess and the foramen and so forth. And this is the over-the-top part. You can see we can go over the top into the lateral recess and the foramen on the other side. Over the top, there's a movie about that. I just want to remind you of that if you're interested, maybe Saturday night on the way home. So, and then finally you get your final CT scan or X-ray, and you can make sure that everything looks good. We use it for bone harvest in the iliac crest and navigation for iliac screws. And then finally we expanded using it not only for instrumentation, but now we use it for pretty much every pathology. We use it for thoracic tumors, for thoracic disc herniations, cervical foraminotomies at C6, 7. I do a lot of cervical foraminotomies. And navigation makes it so much easier. You don't have to struggle with the shoulders. You don't have to struggle with X-rays. You navigate it, and you know exactly where you are. There's a thoracic discectomy, so you can get really beautiful scans. This is just an example to show you, even though the retractor is in place, you've got a lot of air, you still get a good quality scan here. We published our experience on total navigation, and we showed that we eliminated fluoroscopy in about 75% of our cases. The only cases, again, that we still use fluoroscopy is lateral surgery. There's a tumor case, an extraforaminal tumor that was done MIS with navigation. And by using navigation, it just facilitated the lateral the posterior lateral approach. So we avoid the facet joint, and we did this through a tubular retractor. We could resect the tumor under the microscope with navigation, and that just makes sure then that you got the whole tumor out. You preserve the facet joint. You don't have to fusion. You don't have to do a fusion. We do a lot of single-stage surgery now. We heard about that yesterday. There's a case. We had a fusion done and had adjacent segment disease above and below. We did an ALIF from the front and then a lateral surgery at the level above. This was done single stage, so we did lateral surgery, ALIF surgery, and then screws from the back. And this can all be done with navigation, except for the lateral part of the surgery. Again, for that we use fluoroscopy, And the challenge now is really to figure out how can you also do the lateral surgery with fluoroscopy. And I think there are a lot of challenges, but we and others are working on that. Putting in the screws in lateral position is a little bit of a challenge. One of the key aspects here is before you put in, when your patient is in a perfect lateral position, I rotate the patient. Then when I'm ready for the screws, I rotate the patient away from me, and then I get a scan, and that makes it easier to put in the screws on the opposite side. But you got to get the scan after you rotate the patient. If you get the scan before you rotate the patient, it'll be inaccurate. But if you rotate it later, this is one of those little tips and tricks that you learn when you do this type of surgery. No, the beauty now is that if you can't really trust your indirect decompression, you can still do a lateral decompression in a lateral position with tubular decompression. And as a matter of fact, having done now a lot of those, it's almost easier to do tubular decompression in a lateral position than it is in a prone position. And we do it now all the time in patients where we're not 100% sure, well, did we really get a good decompression with lateral or ALIF surgery? We drop a tube, and then we just do a quick decompression under the microscope in the lateral position, and we use navigation for that as well. And it works fairly well, and it's pretty straightforward. This is an example where we did that, where we dropped the tube and with navigation here and did a decompression. And we have a poster on using 2D navigation for lumbar surgery downstairs, and don't worry, we took it out of the award session, so we didn't want to award ourselves the best poster, so don't worry about that. I want to show you a few slides about augmented reality. Augmented reality is an enhanced version of reality where live, direct, or indirect views of physical, real-world environments are augmented with superimposed computer-generated images over a user's view of the real world. It sounds very complicated. What it means, essentially, we use it with a microscope, and we inject images of structures that you can't see because they're under the anatomy, and you can see them through your microscopic view or through the exoscope, and it can help you primarily in your trajectory planning once you're in there. Now, we have a post on that. Again, we're not going to award ourselves, don't worry. This is a case, a sacral tumor that we treated and what we combined with augmented reality. So we marked it on the MRI and on the CT scan, and then under the microscope, we dropped the tubular retractor, and you can see the outline of the tumor here. The dura has been opened, and the tumor is right under the outlined structure, and we removed the tumor very successfully. Raj has it in greater detail as a case presentation, and that's the tumor coming out. This is a case where a patient had a big herniated disc and a synovial cyst at the level above, and we used augmented reality. This is a little bit hard to understand if you're not used to looking at it, but we marked the disc space. That's the herniated disc. That's the synovial cyst. So it helps you in terms of your trajectory planning when you drop the tube. Where do you do your laminotomy? How do you have to angle your tube? Can you get there through one incision or two incisions? So it helps you with all those little decisions that you have to make in the operating room. This is again, so we're looking through the microscope. That's the herniated disc underneath the dura and underneath the bony anatomy, and that's the synovial cyst further up that we have to address later on. Now, the last thing I want to show you is that we've done a lot of work with the AO and others on identifying workflows for MIS procedures. For example, we published a paper where we broke up the over-the-top decompression for lumbar stenosis surgery into multiple steps, and we can teach that with PDFs, with a real spine model under the microscope. We're doing the same now with MIS TLIF. MIS TLIF is a very, very standardized procedure, and it's based on landmarks. You can teach surgeons to do this procedure. The first landmark is the inferior lamina. Then you drill, you disconnect the inferior articulating process here. You're looking for the pars. The next thing is you got to find the pedicles to remove the superior articulating process. So those are all bony landmarks that you can identify on a CT scan, and then you can inject those into your view under the microscope when you do the MIS TLIF. And we did that here. So this is the disc space. This is the inferior edge of on the right side at L4-5. This is the inferior edge of the L4 lamina. This is the pars, and these are the pedicles. So these are all the landmarks that you need to do this operation. So we're doing a series of TLIF cases now where we use augmented reality to really find our landmarks very quickly, and that can be very helpful in patients with overgrown facets, for example, or patients with more complicated anatomy. So this is one of the potential useful applications of augmented reality. In this case, this is the L5 pedicle here. We want to make the cut right above the pedicle to remove the facet joint, and augmented reality shows you exactly where to make that cut and then where the pedicle is above. So that was really what I wanted to talk about. So I think that navigation makes you a safer surgeon, a more accurate surgeon. You can eliminate fluoroscopy. We have to talk about the radiation for patients, of course. That's something that we still have to address. I think it can help you in education, teaching, training, augmented reality. I think we're just at the very, very beginning of really where navigation is going to take us. And I think we've got to make sure that we understand that it's really all the same. Navigation, robotic surgery, augmented reality, virtual reality, those are all related technologies. And we shouldn't separate them out, have industry separate them out for us. We should make sure that we look at it as an entity and find out where is it useful and how can we really integrate that into our treatment plan for our patients. Thanks for your attention. All right. I think we're a little bit over time. Oh, no? Okay, good. Any comments, Luis? Or?
I feel a dinosaur. So looks like in the future, we will not need to do surgery, right? We will learn the indications, then the machines will perform the procedures.
Well, that's true. And the most important thing, we talked about the 6 T's yesterday. The first T was target, which is the indication. And we never talk about that, or rarely. What we talk about is the technology, the techniques, the teaching, the training, the research. All that, we can automate. But the level 1, the target, that's something that we're going to be, that's where we're going to be needed. Technically, maybe a robot is going to do the surgery, but the challenge is going to be the indication. And I think if we don't spend more time really becoming good at making indications and right indications, it's going to be a real problem because we're going to become technicians. And then if the robot does everything, then we're not needed anymore. Yes.
One of the challenges I think that we face with these new technologies, particularly on the training side, is we're starting to see people come out incapable of working without them. And one of the problems I have with that is you have less capacity to understand when something's wrong. And if something should fail in the midst of a procedure, it becomes a real liability for the patient and the surgeon alike. So how do you feel like we should be addressing that dichotomy in the sense of training individuals to go out and be able to master things well enough that they can use new technology but not be slaves to it entirely?
I'll be very honest. We have a project in Tanzania. We go to Tanzania every year, and as we've been doing this now for more than 10 years. Initially, we went out there, and what we did was craniotomy for trauma, or Now, as everything becomes more sophisticated, they want to do MIS, deformity surgery, and I could always say, you guys are not ready. But now they're actually ready, and I have a hard time putting in screws with K-wires and fluoroscopy. I haven't done it in 10 years, and one of the reasons why, and then Avelino still does. He goes to Chile. He does TLIFs in Chile, and I admire him for that. I couldn't do it without navigation, and I'll be the first one to admit it. And it's a real problem. Fortunately, we've got 3 navigation systems here, so if one breaks down, we have 2 others. But it is a problem, and I think it has to. I think the solution is going to be a training program that teaches you the basics, and maybe we need a residency for spine surgery. Maybe it's not good enough to do a 1-year fellowship, as an orthopedic surgeon. I think maybe we really need like a residency where you teach people the very, very basics so they can do those things, without the fancy technology. I mean, that's the only solution that I see. As spinal surgery becomes more sophisticated, we have to admit that, and we have to acknowledge that by really creating an environment where surgeons can learn the basics and the complex portions of spine surgery. And the fellowship is not going to be enough. As a neurosurgeon, we're a little bit more fortunate because that's part of our residency, but even that is not enough. So I think it's going to be a spine residency. Yeah. Yes.
I think I'm imagining myself when they invented the X-ray and the discussion the doctors have, and when they invented the ventricular encephalograms, when the discussion the doctors have, and when they invented any new technology in medicine, they probably have something similar to this. There is something I'm not hearing from the physicians here, that when I use the navigation to do a craniotomy or a spine case, I'm still planning it the way I did it before in my head. Exactly the same way I did it in my head. I'm not as young as most of you guys. I came from the era where we were drilling holes to look for hematomas and so on. So what happened to the neuroanatomy and the neurophysiology? This is what makes us a doctor. So we're not going to be technicians. We're still doctors. We still have the three-dimensional concept in our head. So I'm not really concerned about all of that.
Yeah, but you have the benefit of, you went through that, really great training program. You did it that way. A lot of the surgeons now, they leapfrog into new technologies and they don't even know the basics.
But this is our responsibility to keep physicians as physicians. You are a doctor, you go to medical school, you learn ABC medicine, and then we add the technology to it. I see the students nowadays put everybody in the machine. We cannot allow that. It's really our responsibility, and we owe it to the young generation to keep them physicians, not technicians. When I was in last year medical school, my mentor was trained in London, England, and the CAT scan was coming, and he presenting a case. I said, "Oh, we get a CAT scan." Well, I know something nobody else does. So the poor man looked at me, looked down the hole. The man that was cleaning the floor, he looked down and said, "What's this guy?" I said, "He's cleaning the floor." He said, "Tomorrow I'm going to give him authority to order a CAT scan. So we don't need you here." We're going to have to keep that in mind. If we don't keep the young generation doctors, not technicians, we lost the battle.
Yeah, I think that's why we need to talk more about indications and not only technologies.